Welcome to the next episode of Mic'd Up with Chiro Up. This is going to be a presentation after I gave the presentation in Vegas for Parker Seminars in 2025. This was a really cool talk. It was developed by Dr. Bertelsmann and myself, and he came up with a flow on how to do this podcast. I was fortunate enough to be able to present it, and I want to give you, the listeners, maybe a different view of this talk. You know, one of the interesting things about giving talks at a state association or hospital system or what have you is that you never see your notes. And I think that's a disadvantage both to the speaker and then also the audience because, you know, there are nuances that you're going to forget throughout that presentation. However, for this scenario, for this platform, I have the notes in front of me, so it's going to help me out significantly. So for the purpose of this podcast, I'm going to give you one cool quote that I want to explain in depth. I want to give you some content on mastering hip pain that I use every day, and I think most people in the profession, and really any healthcare profession, use every day. And then I'm going to round the podcast out with something that we dislike. It's a topic that we dislike. That's okay. It's about signing our soap notes. But then I'm going to give you a little snippet on how to make sure all these notes are done, that they're all compliant, and that your business is protected. So to get on with the podcast, like always, if you like Mic'd Up with Chiro Up, a couple things that we'll ask of you, please share it with your friends. We always appreciate that. Like it or do whatever you do with normal podcasts or Facebook posts or Instagram posts. And then also, I think that the one thing that I want to highlight before we kind of dive into this is a unrecognized consequence of doing a podcast. And that is that this is a clinical podcast. Obviously, this has come from two chiropractors. However, I get just as much feedback from people who are not chiropractors as I do from chiropractors. And I really don't discourage this. In fact, it's been really quite fun communicating on a surface level. I mean, obviously, I can't get into too much detail about specific medical conditions. However, from people really around the world about their conditions and then providing some insight. And the number one thing is I've been able to use the Chiro Up Finder that's already in your platform. So Chiro Up Finder is able to find and locate Chiro Up providers around the world. And then now when I'm getting these pieces of feedback, I can actually send them to a chiropractor in my area. I need to turn this into my side hustle though, because I'm starting to send out a lot of referrals, which obviously I appreciate. That's the purpose. And I really do encourage that. An interesting thing about seminars and meeting people around, chiropractic seminars is that they almost feel like they're a nuisance or that they're taking up my time. And I don't want to speak for Dr. Bertelsmann, but at least for myself, and I know he would resonate with this, is that we enjoy this. This is our jam. The clinical aspect of what we do is what we do. We love this aspect of getting out and speaking. However, let's dive into the podcast. First, I want to give you one piece of a quote that I gave in that presentation, and it was, I believe, an old African proverb. I'm actually not quite sure where it came from. But if you want to go fast, go alone. If you want to go far, go together. And most of us have heard that quote before. However, that's one of the critical aspects of Chiro Up, is that we could have easily turned out an EHR, turned out an exercise program, very simple and easy to do and coded and out in your hands. However, it's really the feedback that you provide to us that we have that together mentality of let's make a product, let's make a company for the profession instead of just churning out random products that do small things. Let's turn it into one platform that can do everything for us. That is evidence-based chiropractors. We can really dominate the world when it comes to musculoskeletal care. I think that's the kind of the mantra that we're getting as we go out and we talk with these populations. So in the actual presentation for Parker, this is a presentation, and I really do appreciate what Parker does. When I was in school many, many moons ago, Parker had a different mentality, at least from what I was told. And to be honest with you, I was not at those seminars. However, the one thing that I really appreciate about what Bill Morgan is doing at Parker is that when I get an invitation to speak, they don't tell me what to speak about. In fact, they just give me a time slot and say, speak about whatever you want to speak about. I really do appreciate that, because what I'll do is I'll take a topic or a patient demographic or a concept that I really am limited in my clinical ability. And then I spend 9 months researching and developing a presentation based on that to improve my clinical acumen, but then also to share that with other people, because I'm assuming that if it's an oversight or a weakness on my end, that maybe other people are also experiencing that. 3 years ago, I gave a talk on chronic pain. Last year I gave a talk on vertigo, and then this year was on hip pain. And this talk, started off with a quote by Hippocrates. Yes, I know puns are the absolute lowest form of comedy. However, Hippocrates really was the father of patient-centric care. In his quote, "It is far more important to know what person the disease has than what disease the person has." And the thought behind that is that many of us are very good at getting the actual diagnosis. They have hip osteoarthritis, they have plantar fasciitis, they have rotator cuff syndrome. However, this quote is really centered around what person the disease has, meaning the person. What person created this disease? And instead of focusing on the diagnosis, which is, kind of what happened, what tissue finally gave way, we can really look at orthopedic testing to confirm a diagnosis, and then dive into the curiosity, dive into the art of understanding what are the underlying reasons that this person has the disease. And I think this is so interesting, and this is what I'm going to cover today, because I'm going to talk about the Faber test, and a test that you and I and everyone else can do. You can master this test in about 10 seconds after watching a YouTube video. Anyone can do that. However, really, can we stop wasting time running through just random tests, and actually can we streamline our evaluation? And let's focus on the most sensitive, the most specific test for each diagnosis, because you and I know that we trade time for money. That if you're going to get the best clinical success and patient satisfaction, it's how you interpret the results of these orthopedic tests or testing clusters to tell the person what's wrong and what we're going to do about it. So as far as a Faber test, I'm not going to rehash this, but taking someone through, some flexion, some abduction, and external rotation of their hip, and we can all do that. But really, when you do that, we're looking for the location of symptoms. What's happening to their pain? Does it reproduce their chief complaint? And there are 4 things that I covered in this presentation. And the last one, really, unfortunately, is probably the most common, which is gluteal tendinopathy. Gluteal tendinopathy is by far the most common problem when the pain is on the lateral hip. During this presentation, I only had an hour. I couldn't get into that. I highly recommend, if you haven't done so in a while, go into the condition reference section in ChiroUp and read up on that section. And it's so interesting because that one diagnosis probably has the most updates. That the research on tendinopathies and tendinosis is just exploding at this moment. So I think that's something that we can all not only learn about now, but also as the months go on, lean on our team and lean on the software to help keep you up to date on how to diagnose it, some ideas on how to treat it, and then of course the rehab stuff that you can do with your patients and also with your patients at home. But for this presentation, really what could happen? Really, you could have increased groin pain, which is probably the most common. You could have decreased groin pain. That's an interesting one, right? So what happens if you do an orthopedic test and the pain goes away? Well, it's not a negative orthopedic test. It's still changed symptoms. So in your notes, say Faber test was negative or negative for pain and actually took the pain away. That still means something to you, and it means something to your clinical note. And then, of course, we could have increased posterior buttock pain or sacral pain right there by the PSIS. So we can generate a lot of information from one orthopedic test. And really, what is orthopedic testing? It's compressing it, it's stretching it, or it's making it work, and then kind of seeing what happens to those symptoms. Let's cover the first one, though. Let's go into the first symptom, which was increased groin pain. And this is the most common thing that we'll see. And Faber test, just so for some schools that teach this, this is also Patrick's test. So same thing. Obviously, there's a lot of different names for a lot of different orthopedic tests. However, Faber test is super sensitive for hip joint issues. However, it's super unspecific. So it really doesn't tell you what's wrong with someone. It just tells you there's a problem in the area, kind of like the C sign. So we know that we have probably a hip problem and not a back problem. So what I'm going to do throughout this presentation for today is not only go through what test is positive, but also once that test is positive, what is the next test? So if Faber test is positive for increased groin pain, what other test, clinical signs or symptoms should you be looking for to come up with the actual diagnosis? So Faber test says hip. Now what's the next best orthopedic test to identify the exact tissue diagnosis? So the first one, if we have a pain that gets worse, increased groin pain with Faber test, and I have a young population, man, I'm really going to dig deeper into and ask questions concerning a labral problem, because a Faber test has a high sensitivity and specificity and positive predictive value for identifying labral pathology. Now, normally this patient population is going to be your 20 to 30-year-old. Females usually have it on both sides, males usually on their dominant side, and this is going to be someone who has repetitive hip flexion and rotation. So this is your basketball player, your soccer player. But remember, FAI, or femoral acetabular impingement, really can be combined into three different categories, which we're going to cover. Most of the time, this is a purely generic statement, but we're going to get CAM lesions or bony problems, which we'll cover later on this podcast, with our young athletic males. And then usually our pincer lesions, which is a labral-only lesion, is going to be our physically active middle-aged females. Now, you and I know, and the research shows that 72 to 80% of all CAM lesions are mixed, meaning they have a little bit of both. So I don't get too excited about the stats. We really need to identify the person, not necessarily just say, oh, this is a male or female. They're probably going to have, X, Y, or Z. And remember, what is happening here? So when we look at if you look at orthopedic conditions like Osgood slaughter, that's a patella tendon pulling on a tibial tuberosity. And at a certain age group, unfortunately, that apophysis, the tibial tuberosity, is weaker. The apophysis is weaker than the tendon, and it's going to pull away. So the weakest part of that entire complex is the growth plate, and that's why we see injuries. Same thing if you drive down lower, maybe like a Seaver's disease. The calcaneal apophysis is weaker than the Achilles tendon in a younger person, and that's why we see Seaver's disease. But what happens when the person's 30? They're going to have Achilles tendinopathy. What happens when they get older? They're going to get, maybe plantar fasciitis. What happens when they get older? They're going to have actually calcification or heel spurs within the plantar fascia. So really the end of the story is these structural changes are just happening. They're happening due to the physiologic changes, the active, repetitive stresses we add to our body, or even the postural stresses we have to the body. And what you and I need to focus on is what is the weakest point now. Because in a 12-year-old, they could have Osgood slaughters, then maybe Sidney Larsen-Johansson, the patella tendon, and then they're going to actually get tendinopathy of the tendon. Then they're going to get, some osteoarthritis of the knee. So every joint has a continuum of dysfunction that we need to be aware of, and focusing on the patient demographic will help lead us into that appropriate diagnosis, but also even more so the prognosis. Because a simple sprain has a sprain has one prognosis, a torn tendon has another prognosis, or a growth plate fracture has another prognosis. So keeping that in mind will help you help your patients. So when it comes to pincer lesions, just like any other hip problems, that repetitive flexion, adduction, internal rotation that you're going to see in things like swimming, you're going to see in pitching as far as the plant foot when they're pitching. That is one piece of the puzzle, but don't forget that not all injuries are repetitive stresses. In fact, a good portion of your patients will actually have postural stresses that cause their pains or their problems. If you look at the hip, just sitting for a long time can cause a lot of stress on the anterior superior portion of the femoral acetabular joint. So something else to think about. It may not be the activity, it could just be the posture. Now, the vast majority of pincer lesions, we're looking at our young, physically active people. They get this dull, achy, insidious onset. It's right in the hip. It's worse with some activity. This is something that, we do the Faber test and it's positive. What is the next test? So think about that. Think in your head right now. What's the next test, orthopedic test, that you would do on someone to identify, is this a pincer lesion? Well, what the research says is the hip posterior impingement sign. That this test is having the patient prone and bringing the hip up into extension and then going into some external rotation. And pain that's in the front part of the hip when you do this test, if you want a video demonstration of this, obviously hop on to Chiro and I'll show you how to do this. This is very simple, and you're going to identify that very localized anterior hip pain. Now, if you have a pincer lesion with a patient, the traditional considerations. Now, I'm going to speak to my age a little bit, because when I got in school, it was, hey, if you have any kind of FAI, they go to ortho immediately. And I will say that that's what I did for the first 10 years, because the considerations and what the evidence said to do is to maintain physical condition. However, avoid hip flexion, avoid internal rotation, stop squatting. Stretching is counterproductive. Avoid hip mobilization manipulation. That is what I was told, and that was what was in the research. In fact, I used to put people in a donjoy. It was called a surf brace, stability through external rotation of the femur. This is what I did. And I'm not saying that it was detrimental to my patients. I was just following what the research said. However, in the last year, I put some time. I put a little energy into this and said, what should I be doing to these patients? And what I found from the papers, and I'll have in this podcast, we'll include a link on here and give you the research articles. But really, for this kind of situation, I found studies that said, listen, we need to rehab these people with a labral tear. We need to focus on hip stability, core stability, and mobilizing the hip. This is all stuff that we can do to improve function, reduce pain. And in fact, after they have any kind of hip arthroscopy, if they were to have that, they still need to go through stability exercise, proprioceptive training, progressive mobility restoration. These are things that we can absolutely do. So make sure that you go through and go back into, whatever resource you use and learn how to mobilize the hip, how to manipulate the hip. Personally, I do mobilize the hip versus manipulate the hip in this kind of population. Adding that extra grade 4, grade 5 mobilization may not be the first choice, but you can get into that as that tissue starts to calm down. Now, when it comes to treatment for the actual FAI with a pincer lesion, I'm going to do some hip stability stuff. I'm going to teach them how to squat. I'm going to use some side bridges. Side bridges with an isometric hold is a great hip stability exercise. Easy on the patients, something to consider. Now, what happens, just out of curiosity, what are you going to do when you do Faber test and they have decreased groin pain? So this is the number 2. If you have decreased groin pain as you do this, they could still have an FAI. Now, in this case, it'd be more of a CAM lesion, but it is very important when you do your orthopedic evaluation to document positive tests, but also negative tests. For those of you who are already using the EHR, this is something that, when you get to visit 4, visit 5, and someone maybe isn't progressing like they thought they should, go into those tests that should be negative and assess those. If someone has a back problem that's not getting better and you never assess the hip, well, that's fine. That's okay. Now it's like, well, maybe it could be a hip referral. Maybe it could be a space occupying lesion. Maybe it could be something else. That's why we include negative tests in the EHR to just provide thought-provoking differential diagnosis possibilities. Something that's pretty neat. Now, what am I going to do to help differentiate if someone has a cam lesion? Well, like I said a couple minutes earlier, is that our males, if Faber test is positive, 88% of all hip problems have a positive Faber test. That's good and great. However, how can we now localize this problem? Fadir test, Fadir. It's always nice when it sounds exactly like it's spelled. But this is when we're going to go through some flexion adduction and some internal rotation. And now we're going to put a nice little shear force across the acetabulum and across that labrum. And when the patient's laying down, they're going to let you know. They're going to say, hey, that reproduces, my pain. I will say historically, while there isn't as much research on it, I used to use the quadrant test that I liked a little bit more. Unfortunately, with the quadrant test, that's when you bring the leg up into 90 degrees flexion from the supine position, and then you just bring the whole leg into adduction. I have found that if they have a lot of hypertonicity in the glutes and the piriformis, like most of these people have, they also have a positive quadrant test. So I don't think it's as good. However, also a very viable test that you can use. Now, this is where I want to change my story just a touch. And it's not really my story. I think, as a provider, hopefully, as I've already alluded to, even within this podcast, is my opinion is going to change. It doesn't change weekly, but it does change as the preponderance of evidence starts to point in a different direction. This is something that if I do suspect a cam lesion, I am going to take some images of. And unfortunately, people with a cam deformity, surgery, and don't shoot things at me, don't blow up my email box, but surgery can be effective. And the reason I say that is that unfortunately, what the research is telling us is that they have a bony block. They now have a problem in their hip that they can't get adequate motion. And unfortunately, not only does it limit flexion because of pain, but also extension due to that pain response, that they are going to compensate and they are going to squat a little different. They're going to sit a little different. They're going to run a little different. And this can cause problems. So I am not saying everybody has to have surgery. However, I am always referring my young athletes, if they have a cam deformity, to an ortho to just have two eyes on that situation. And that's when you really want to have an ortho in your area that that you trust, that you can text and say, hey, I'm sending this patient over. Here's what I'm thinking. What are you thinking? And by no means am I going to tell him or her what I think we should do. Let's just get another opinion. Really, we're all doing this for the betterment of our patients. And I think if you can have those relationships, it only helps strengthen the bond between you and your patient if they know you're looking out for their best, their best health, essentially at this point. As far as treatment for that, it follows almost the exact same treatment pathway with mobilization, manipulation, and doing a lot of hip stability. With any exercises, we never want to go into sharp pain or shooting pain. If you're diving into those areas, that we're stressing tissue that's already a little injured, so maybe back off just a touch. Finally, let's go into the last piece of Faber test, which is increased posterior buttock pain. This is one of those that, I always think of realtor.com as location, 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 because when you do Faber test, it really can reproduce pain all over the place. But if you do get pain that goes into the posterior buttock, or really right next to the PSIS, we should be thinking about the SIJ, the sacroiliac joint. This is one of our home run cases, and unfortunately, there's a lot of people that can have these problems. You can get sacroiliac joint pain from mechanical sources like gait or abnormalities or pes planus or improper shoes, any number of things. It can also be temporary. So one of the most difficult patient populations to treat are pregnant patients because things are getting weird. They've got some issues. Those issues are going to be gone in 9 months. However, blood volume's changing, hormones are changing, activities are changing, the way they sleep is changing. So we see a lot of SIJ problems with prego patients, and then arthritic patients. People have ankylosing spondylitis or arthritis, enteropathic arthritis. All those can affect the SI joint. So something to think about. I will say that out of all those, while I said pregnant patients are weird, they are by far one of my favorite patients to work with because they're not complaining. They're not just that patient is complaining about having, X, Y, or Z wrong with them. They have a complaint. that they're looking for a solution. And in the world that they're living in right now, that non-surgical, non-pharmacological option is us. So make sure that you have ways to treat those patients and rehab exercises for those patients. One of the I love it when I make myself laugh. My wife does all the videos. So everybody uses ChiroUp, sees all the rehab. And 15 years ago now, Tim and I went to a modeling agency to find someone to do our exercises. And for cost reasons, because we had no money, and for purposes of renting a studio and having the same person on every single video for the last 15 years, we thought to ourselves, let's find someone, who's close to us. And we all drew straws, and my wife had the short straw, so she lost. However, when she was pregnant with our third child, she was so excited. She was like, no videos for 9 months. And I laughed right back and I said, absolutely 100% videos. Now we actually have a pregnant patient that we can do videos with, because that's one of the hardest things to do in a pregnant population is to have them understand that movement is important and also these movements are safe. So what you'll also notice is that in your exercise videos in ChiroUp, the ones that do have pregnancy next to them have a pregnant model in the background that just happens to be the model for all the other videos. A little fun tip of the day. When it comes to sacroiliac joint dysfunction, what are we going to do to help identify or localize that? And actually, we use something called the thigh thrust test. The thigh thrust test is a cool test because there was a paper in 2020 by Nahati that said if we just can use these two tests, the thigh thrust and the Faber test, I forgot the sensitivity and specificity. It was in that 98% range. So we're going to see a very easy way to identify the localized area for this problem. And then, like all SI joint problems, we're really good at getting those to go away with manipulation, manual therapy, and exercise. So using those are going to be critical. So that was kind of the basis behind my presentation at Parker. If you have any questions, as always, send me an email, brandon@chiroup.com. I'd be happy to answer any questions. I do want to go into, I guess it would be new functionality, but new functionality for a reason with my own personal clinic, because what we had is when moving EHRs, we noticed that a lot of things were not cleaned up and tied tight. And one of those things is, to be honest with you, all providers, I'm not going to name any names, including myself, we had unsigned notes. And it wasn't a lot, but we did have some. And unsigned notes are a big deal. You go through 10 years of using the same system, those start to add up. And by no means is it a policy or something that we constantly do, but things get missed. So one thing that we did that we just released is a section called unsigned notes. And I thought about this, and we have a bus policy at Premier Rehab, which is the chiropractic clinic, and at ChiroUp. And the bus policy, however morbid it may sound, but if someone gets hit by a bus, what happens to the business? Does the entire business depend on that person for whatever it is they do? And unfortunately, if you think about it, is that if you have an associate or independent contractor or yourself that gets hit by a bus, is your business protected? So one of the things about not getting your SOAP notes done is that there are insurance and legal issues associated with that. Besides claim denials, by not having your notes signed and dated documentation, and they can deny that claim. We really want to have those for any kind of audits or recoupments, repayment demands, if that falls into your state or what's happening to you, that can really result in loss of billing privileges if we don't have those notes. So we really want to make sure we have all those done. And really the standard is about 24 hours because when I talk with malpractice carriers, if it's not documented, it didn't happen. And if it's not signed, you're not getting paid and bad things can happen. So we have a strict policy in our clinic at Premier Rehab. We say 48 hours, but really we want it done within 24. The reason we have 48 hours is that some of us, are not there the next day. So by the beginning of the next shift, your notes have to be done. Always sign, always date. It has to be electronic because we don't use paper. And we have a compliance program to do that. However, what we did is we made the compliance program a little more automated in the fact that our person who does our, however you say it, pays our bills, pays us, our accountant, they actually look in a section in our EHR called unsigned soap notes. And then they run a report. And if in February you have unsigned soap notes, in March you don't get paid. And while that sounds, strict and it sounds kind of mean, it's amazing. All 3 chiropractors in our office, including myself, we have all of our soap notes done because I care about getting paid. Now, I'm not saying you need to be that strict in your office, but it sure has worked in my office. So one thing that I think has been interesting, keeps us compliant. You can come up with your own rules and regulations and policies, but that's one thing that I know that I feel better about. Because if something happened to someone else in my clinic, I know there's the documentation to support that. That if that associate were to leave, I now have those things in my back pocket to get that reimbursement back. Well, I'll tell you what, this was a fun podcast. I try to keep these things, around 30 minutes. And if you have any questions, any concerns, please get back to me. I did have an interesting conversation with many past subscribers, past classmates in the last couple of weeks, and I have all my notes written down. So the next couple of podcasts, we're going to include a lot of subscriber feedback and also chiropractor feedback into the podcast. I just wanted to share a couple things in this podcast, and most importantly, not necessarily Parker, not necessarily your state association. I don't care where you go. Go do whatever it is you want to do, but don't sit behind a computer and get your CE. And the reason I say that is because when you can attend events, whatever event that may be, whether it's a mastermind, whether it's a state association, it's the conversations you have next to the bar, in the hallway, in the morning getting coffee when you're getting ready to go into a class. Those are the conversations you need to be having. Talk with your classmates, talk with your mentors, because those are the kind of conversations that you can really get your questions, your personalized things answered. And let's get back together. Let's stop doing things in silos. Let's have more of a camaraderie as a profession, and as together, I think we're gonna continue to grow. So once again, if you have any questions, concerns, email me, Brandon@chiropractor.com. Otherwise, please share this podcast. We're trying to continue to grow. The more comments, the more likes, the faster we move up those rankings in Spotify and also Apple Music. So I really do appreciate those of you who do listen to the whole thing, and I'll come at you next month.
Hey, thanks for listening. To access more information, visit chiroup.com. You can sign up for a 14-day trial. Use referral code podcast15 for a special discount after your trial. Offer valid on new subscriptions only.